Alberto, hi.
Hello.
Hello, this is Dr. Bülent Urman.
Hello. Hi. How are you?
I'm fine. Very nice having you with us.
Yes, it's my pleasure. Thank you for the invitation. And sorry
Yes.
if I am not here with you, but I had a very small accident. So,
Yeah, I heard that. We're very sorry for you. Wish you were here with us
no,
today.
yes,
Anyway, I mean, we are used to these online meetings after COVID. So,
yes, it's okay. It's okay.
so let me briefly introduce you and then we can immediately go ahead with the talk, okay?
Yes, thank you very much.
Um, so, today our guest is Alberto Vaiarelli. He's a gynecologist and fertility specialist and medical scientific coordinator at Genera, Rome. He's a member of executive board of Italian Society of Fertility, Sterility and Reproductive Medicine, and he's currently the national secretary as well as member of the scientific advisory board of the network of Italian IVF units. So Dr. Vaiarelli did his Bachelor of Science Medicine degree in Messina. He did a clinical clerkship in Virginia, in Richmond, USA. And after that, he specialized in obstetrics and gynecology, again at the University of Messina. He did a PhD in reproductive endocrinology in University of Messina. He did a research fellowship in reproductive endocrinology and infertility at Yale University, USA. And later on, he did a postdoctoral researcher. He worked as a postdoctoral researcher again at University of Messina, a clinical fellowship at the Brussels Fertility Clinic, and he did an andrology and reproductive medicine subspecialization in the University of Padova and assisted reproductive technology in the University of Urbino. Am I correct with all of these?
Yes,
Albert?
yes, it's okay. It's okay.
Yeah,
Everything is good.
you have a very impressive CV. So we're anxious to listen to you, and the title of the talk will be From Science to Success, LH and Gonadotropin Strategies. The
So,
floor and the screen is yours, Alberto.
thank you very much for this presentation. I would like to thank all of you to be here. And unfortunately, I am here because I fell down the stairs, and so very small accident. But anyway, so thank you, Merck, for this invitation. And it's very my pleasure, my honor to today to try to discuss with you regarding this important topic. I think so. I'm a gynecologist. I work in a big private IVF setting. And I would like to start with these slides because, of course, it's crucial for us when we have a patient in front of you to try to analyze which is the measure of the success in IVF. Because the success in IVF is a complex definition, because of course the efficacy of the treatments means to improve the cumulative labor rate. Today, in the majority of the case, we use the cumulative labor rate to assess which is the success in IVF. But also, it's an important point to analyze the efficiency of the IVF. So efficiency means try to reduce the adverse event, for example, such as hyperstimulation syndrome or multiple pregnancy, try to reduce the time, try to improve the cost effectiveness, try to reduce the dropout. So what I'm trying to say is that when we talk about the definition of the success is a complex definition, and many factors we have to take in consideration when we analyze this endpoint. Of course, the ovarian stimulation is a crucial step. So we know very well that when we have a patient in front of us, our goal is to try to obtain a good quality of the embryo in terms of quantitative and in terms of qualitative. We spend a lot of effort to avoid the hyperstimulation syndrome, because we know very well that the hyperstimulation is an important complication in IVF. But of course, I think today if our measure is the cumulative labor rate, we have to try to avoid the hyporesponse, because hyporesponse means that in patients population with a good ovarian reserve, at the end of the stimulation, we obtain a few number of the eggs according with the antral follicle count. So the hyporesponse, if the cumulative labor rate is your outcome, is something that we have to avoid. Today, for me, the goal of the stimulation is to try to improve the ovarian sensitivity. And today we have two important indicators. So one is the fourth index. Fourth index means the correlation between the antral follicle count and the pre-ovulatory follicles, and the FOI index. FOI index is a follicle to ovocyte index, the correlation between the antral follicle count and the number of the eggs. So thanks to these two indicators, we can assess the quality of our stimulation in terms of follicular recruitment. So the correlation with the number of the eggs and the cumulative labor rate is very strong. And so it's logical that if we are able to increase the cumulative labor rate, we will have more embryo and more cumulative labor rate. But however, when we want to stimulate our patients, we can personalize the treatment at a different level. In particular, in poor prognosis patients, for example, in patients with advanced maternal age, and in patients with low ovarian reserve markers. But what I want to try to share with you is that how many steps we can personalize. We can start from the pre-treatment strategies. This is what we do in our clinical setting in order to synchronize the cohort of the follicle with the estradiol valeriate. For example, this can be the cheaper solution in order to synchronize in antagonist protocol the cohort of the follicles, but you can use the antagonist injection or the progesterone. Regarding the oral contraceptive pill, I am not totally agree to use the oral contraceptive pill because some data support that the oral contraceptive pill can reduce the cumulative labor rate, but this is just an important step. Of course, we can have different protocol, antagonist, agonist, PPOS. We can use different gonadotropin, urinary recombinant, biosimilar, LH activity with LH or with the HMG, and also we can use the adjuvant treatment. The last but not the least, we can use also a single approach or a multiple cycle approach, and in the second part of my stimulation I will focus my attention on this concept. However, the point is that we can do many things, but the question is still open regarding the real value of all these personalization when we treat infertility patients. So up to now, what we do today in our clinical setting is to try to tailor the ovarian stimulation according with the antral follicle count and according with the MAH. Of course, the age represents another important indicator, but not to assess the ovarian response, but in order to assess the quality of the eggs and the quality of the gametes. But what we can have, we have different patients profile, patients with expected hyper response. Of course, in these patients, the number of the eggs maybe is not a big problem, but we can have patients with expected normal responder. In these patients, for me, it's mandatory to try to maximize the ovarian response if your outcome is the cumulative labor rate. And of course, another challenging is the patients with expected poor response. So in these patients, we have to try to do something not only to increase the number of the eggs, but also to take in consideration the efficiency of the treatment, time, dropout rate. Of course, in the future, I'm totally sure that something will change because the expansion of genetic assessment is something that we will use in the near future to tailor the stimulation, because maybe the pharmacodynamic approach will be the future in order to try to individualize the genetic patient's profile of the patients, just for example, in order to individualize polymorphism of the FSH, LSH, LH receptors, and according with this polymorphism, we can tailor the treatment in terms of starting dose, in terms of LH activity. But what we know today, according with the concept of the personalization, is to try to collect a correct number of the eggs in every single group of the patients in order to obtain one competent embryo. One competent embryo for me means one blastocyst and one euploid blastocyst. And so if you have a patient in front of us, young patients, maybe 4 or 5 eggs, should be enough to obtain one single good embryo. But theoretically, if I have a patient at 41, 42, so in this group of the patients, we need more eggs to obtain the same identical goal. This is just to realize how is complex to obtain one embryo, because the age will have an impact in terms of lower blastulation rate when we increase the age and higher aneuploidy rate. Regarding the gonadotropin, of course, if you look at the Escher guidelines, you can see that you can use whatever you want in terms of to stimulate our patients. But what I want to discuss with you is that the majority of the evidence coming, the majority of this conclusion coming from evidence in which the protocol used was the agonist protocol. And I don't know you, but in our setting, we use a 90% antagonist protocol. And another important point was that the main outcome of this paper was the fresh embryo transfer and not the cumulative LIBOR rate. So this means that the cumulative LIBOR rate is a new indicator, said we need data to assess which is the ideal drugs to improve the cumulative LIBOR rate in our patients. I want to show you my data. This is the paper that, this is the study that we presented some years ago in Escher meeting, in order to try to understand which is the first line of the treatment when you have naive patients, so patients without any previous cycle, in which you have to select which gonadotropin use. So this is the retrospective study, patients with advanced maternal age. This is the mean age of my population, unfortunately. Antagonist protocol, and in this patient's population, we use in the majority of the case PGTA. So 2 different arms. Our goal was to assess the competence of the oocyte coming from 2 different type of the gonadotropin. And the primary outcome was the mean euploid blastulation rate per metaphase 2. So with 1 indicator, so we have the fertilization rate, the blastulation rate, and the aneuploidy rate. The conclusion of this study was that if you use the recombinant or if you use the urinary, you will have the same identical quality of the embryo, the same identical euploid blastulation rate per metaphase 2. And so the point is that which is the different. But if you look the different are in terms of the efficiency, because when you use the recombinant, you use less dose of the gonadotropin, we have a shorter duration of the stimulation, but you can increase the total amount of the COX, the total amount of the oocyte mature. So this means that unfortunately or fortunately, we cannot modify the competence, but we can increase the efficiency of the treatment when you use the recombinant product. I don't want to spend a lot of time regarding the cost effectiveness when you use different drugs, because when we want to evaluate the economic cost of one specific approach or one specific drugs, it's important to define which is the end point. Because for me, the end point is the cumulative LIBOR rate. This is the reason why, if you look at this data coming from the north of Europe, you can see that if we compare the cost of the single international unit, of course, we can have drugs a little bit more expensive. But the point is that if I collect more eggs, if I reduce the duration of the stimulation, if I reduce the total amount of the drugs, at the end of the story, the cost will be in favor of in this case, of the recombinant product compared with a urinary product. This is one of the paper I think that everybody knows regarding the effect of the cumulative of the recombinant product compared to the other medication in terms of cumulative libel rate. This is a not randomized control trial, but of course you can see a huge amount of the cycle, and according with this conclusion, when you use the recombinant, you can increase the cumulative libel rate because theoretically you can increase the follicular recruitment. Of course, when you increase the follicle recruitment, when you want to maximize the ovarian response, you can increase the risk to have a OHSS, you decrease the risk, you decrease the implantation rate in fresh embryo transfer. This is an important point. This is the reason why in our setting, in the majority of the case, when we collect more than 15 ovocytes, we prefer to freeze the ovocyte, to freeze the embryo, and then we make a frozen embryo transfer in natural cycle. Why? Because the high level of the estrogen can shift the implantation windows, and also when we increase the number of the eggs, you can increase the risk to have a progesterone rise. So it's something that we have to take in consideration when we want to personalize this kind of the strategies. And another point is that, of course, I don't want to spend time regarding the strategies to reduce the OHSS, because we know very well that if you use antagonist, if you use the agonist trigger, if you use the freeze-all, in the majority of the case, the risk to have a OHSS will be very small. What I want to discuss with you is that the trigger, because the trigger represents for me another important step when we stimulate patients. One injection can compromise all the stimulation. And in this paper that we published some years ago, the idea was to assess the competence of the oocyte when you use ACG or when you use the agonist trigger. And based of our conclusion, the competence seems to be unrelated to the type of the trigger. So this means that agonist triggers work in terms of fertilization, blastulation, and euploidy rate. We have a strong experience with the agonist trigger because we use the agonist triggers also in poor responder patients, when we want to open the possibility to make a back-to-back second stimulation in the same ovarian cycle. And so our idea was to understand if the competence is the same. And the conclusion was that there is no any difference. Of course, we have to be careful, because when you want to use the agonist trigger, of course, this is in conventional approach, or when you want to perform two stimulation back to back, some parameters we have to analyze. For example, the level of the LH at the beginning of the cycle, and the level of the LH the day of the trigger. And of course, when you use the agonist trigger, you can compromise the receptivity when we want to use the fresh embryo transfer. So it's something that we have to take in consideration. Regarding the level of the LH, I think this is an important point, because if you have a low level of the LH the day of the starting dose, the basal level of the LH, you can see that you can increase the risk to have a suboptimal response in terms of number of the oocyte retrieve. And the same things when you have the low level of the LH the day of the triggers, because in this case, when you have level of the LH less than 1 or less than 0.5, the agonist triggers maybe can not have a good ovarian response in terms of number of the oocyte retrieve. What about the LH activity? Because the LH activity is still under discussion. If we go back to the physiologists, FSH alone is insufficient for the full follicle maturation and for the oocyte competence. There is a small amount of the LH in the first part of the follicular phase. Physiologically, this is an important point for the androgen synthesis, and in the second part of the follicular phase, the LH has an important role to stimulate the follicle growth and to regulate the final stage of the maturation. So this means that according with the two cells, two gonadotropin theories, the LH is something important not only in the second part of the folliculogenesis, but also in the first part. And the question is that which patients can benefit of the additionally LH during the stimulation. So the first point is that we have to define what does mean LH-FSH deficiency, because deficiency means deficiency in terms of production, for example, hypo patients, but deficiency can have another means, for example, deficiency in terms of action. This is the reason why we can distinguish patients candidate for the LH activity during the stimulation, hypo patients, patients with FSH LH polymorphin, the receptors, patients with strong suppression of the LH during the stimulation, patients with hypo response, patients with advanced paternal age, and patients with a poor response, poor ovarian response. Of course, in patients with low ovarian reserve markers, you can use wherever you want. You cannot create follicle ex novo. The only goal during the stimulation is to try to promote the follicle grow. And so my goal, if I have 3 eggs, I want to look my antral follicle count. Because if I start from 4 antral follicle count, and if I collect 3 eggs, I did a great job. But if I have 4 eggs, but I started from 10 in antral follicle count with 10 small follicles, of course, maybe I did something wrong during the stimulation if my endpoint will be the cumulative LIBOR rate for our patients. So before the 2001, the only option was to use the HMG if I wanted to use the LH activity. Because we know that in HMG product, we have a small amount of the ACG, and the ACG mimic the action of the LH. But the point is that maybe the LH and the ACG are structurally different, but they activate the same receptors, but in distinct bind sites. So what I want to try to say is that they seems to be the same action, but we have to look what does mean using LH recombinant or using the ACG. So if you go back to the physiologies again, if you look at the LH physiologically is secreted by pituitary, and the ACG is secreted by embryo, by placenta. The LH recombinant has a physiological role in the support the follicle recruitment. The ACG physiologically has a role to support the implantation. The half-life, when we compare the LH recombinant when we compare the ACG, it's totally different. The half-life in ACG is higher. And also the stimulation of the LH receptors when you use the LH or when you use the ACG is totally different. And the last but not the least is the purity. Of course, the recombinant is something that we know that the purity is very high. In the urinary product, we can have 30% of something different because, of course, this is not a recombinant product. So today we have many data coming from in vitro models that when we explore the LH activity with a recombinant or with the HMG, so the LH activate different pathway compared with the ACG. So here it's very simple to see that the LH activate an anti-apoptotic and proliferative effect. The ACG, this is the evidence coming from in vitro models, activate different pathway, and the pathway is apoptotic signaling. So this means that they bind the same receptors, they are different, and the signaling in the cells is totally different. The question is that what's happened when we translate all this knowledge in the clinical evidence, because of course this is something that we have to still explore. I think one of the most important example in terms of where the LH activity can have a role is that in hyporesponse patients. Hyporesponse patients, according with the Poseidon number 1 and Poseidon number 2, because in these patients we have a few number of the eggs after the pickup, but we started from good ovarian reserve markers at good ovarian, at good MH, at good antral follicle count. The question is that why in this kind of the patients I have suboptimal response if I start from a good ovarian reserve markers? And the question is that we have to start something that we have to be explored. Of course, the level of the LH during the stimulation is something that we can know, and maybe we can check in patients with a suboptimal follicle growth during the stimulation, or when we look the level of the LH less than 1.2, because these kind of the patients can benefit of the additional LH or from the beginning or during the stimulation if you start with a single, with only, for example, recombinant gonadotropin. Indeed, here you can see the difference of the LH when in natural cycle, in antagonist protocol, in agonist protocol. So this means that you can have different kind of the patients that can be unable to adapt to the GnRH analogous. And this is something related with the LH deficiency in terms of action, but in terms of only production. So try to individualize these patients, I think is crucial if you want to optimize the follicle growth. What about the clinical evidence? This is one of the papers that I like to show because this is the patient population that we have, 39 with low MH. So unfortunately, this is the patient that we manage day by day. And the question is that where can I see the real role of the LH activity and which kind of the LH activity? Because if you compare the recombinant FSH plus recombinant LH compare with the recombinant FSH and the HMG, you can see that in the recombinant group with the LH, you can increase the number of the eggs, you can reduce the cancellation rate, and you can apparently optimize the implantation. Of course, this is something, this is a retrospective study, but the point is that the LH activity, if you use the recombinant or if you use the urinary, is different, and then you can see some difference. This is one of the last meta-analysis published from our colleagues Albigi regarding the role of the LH in hypo patients. So when we compare protocol with FSH, LH, recombinant compare with a monotherapy only with FSH, we have a significantly different in terms of follicle recruitment. In patients with advanced maternal age, again, after 35, in particular after 35, between 35 39, we have, I think, the ideal population is this kind of the population in which the LH can have a role. And also in very bad patients, according with the Bologna criteria, for example, in this page, this is an interesting randomized control trial published by Umaidan. So this seems to have a role not only in terms of improve the follicle recruitment, but also to improve the clinical outcome. Regarding the progesterone rise, I think this is another important indicator if you want to perform the fresh embryo transfer, because if you have a premature progesterone rise, of course, you can have a shift of implantation windows. And apparently the LH, the combination of FSH LH can reduce the risk of progesterone rise when we stimulate our patients in fresh embryo transfer. Some data, of course, this is just only one paper, but it's something that in implantation failure, what we can do. Of course, the implantation failure is a big chapter. The reason is that in the majority of the cases the embryo, but the point is that how can we optimize all the process in order to have a good embryo, in order to optimize the endometrial receptivity. This is again one of the last papers that I want to show you in poor responder patients. This is the real world study. Of course, the real world study for me represents a good study just to see which is the real benefit when we use different kind of approach, and in patients with a severe or moderate poor ovarian response, the contribution of the LH seems to have a role in terms to improve the cumulative LIBOR rate. And so today, I think what we can see is that, of course, we cannot create follicle ex novo, okay, with a gonadotropin. Our goal is to try to promote the follicle recruitment. When you use the recombinant, you reduce the total amount of the stimulation, you reduce the total amount of the gonadotropin, you reduce the duration of the stimulation. And of course, the LH recombinant can have a role in order to promote the follicle growth, in order to compensate LH deficiency in terms of action and production in many patients' population, in particularly advanced maternal age, patients with a strong suppression of the LH, and patients with a poor ovarian response. Just a few slides because of course the time is maybe is over, and then we have space if there is some question. Is that the patient's population? This is just the picture of my patient's population. I think we have a very big problem, and in the future will be worse because I manage patients every day. In 84% patients with more than 35. And in 46% of my patients, I have patients with more than 40. So this is, I think, a big problem for us because, of course, we cannot change the competence of the eggs with any specific strategies. This is just the mean number of the eggs that I collect in different patients' population. Of course, in the majority of the case, I manage patients with a suboptimal number of the eggs. And also, what I have to try to take in consideration when I treat my patients is that not only the number, but also the competence. Because look, if I have young patients, the competence in terms of blastulation and the haploidy rate will be higher. But if I have patients with advanced maternal age around 40, 42, I will have a lower blastulation rate and a higher aneuploidy rate. So this is something that we have to take in consideration when we want to tailor the treatment and when we want to reach an ideal number of the eggs according with the patient's characteristic. This is our result. Thanks to this approach, thanks, of course, the possibility to increase our cumulative LIBOR rate with some specific approach in clinical setting, but also in the lab, because of course we cannot forget that the lab is crucial for us if we want to improve the success in our setting. Look, in 2010, our overall cumulative LIBOR rate was 26. In 2020 is 36, is 33. However, of course, the age of the population, the age of the woman is crucial because if I have young patients, of course, I can reach a high success rate if I maximize the ovarian response, if I have under control all the steps. But in this patient population, 43, 44, unfortunately, I have to try to make a solution to manage this kind of the patient. Because of course we have the egg donation, but many patients come to us to do something with the donor eggs. And the big problem that we have today is that the overestimation of the chance. This is an interesting survey because we have to realize that the patients come to us and they think that one cycle in the majority of the case will be enough to reach the goal. But is it not true? Is not true, and we have to explain, and we have to be able to explain from the beginning, from the first consultation, that according with the age, with the antral follicle count, or with the sperm quality, maybe one X, or maybe one collection will be not enough. This is the reason why I think this is the time to think in different way, because we know that the folliculogenesis is extremely dynamic. We know that during one ovarian cycle we have different follicular waves. This is the reason why we can start in a random start approach in case of, for example, fertility preservation, but also we can start in the luteal phase. Okay, in this case we have to freeze the embryo, but anyway, you can collect the ovocyte. This is the reason why we published our experience in 2016. Was the first proof of concept of the duo-stim protocol, in which we combined 2 identical stimulation in one single ovarian cycle in order to try to optimize the number of the eggs in a short time frame, and in order to improve the number of the embryo candidate for PGTA. So in this patient population, we use estradiol valerate to synchronize the cohort of the follicles, as I said before, because just to avoid the asynchronism. We use maximal dose of the gonadotropin, 300 FSH recombinant plus 150 of the LH. As I said before, this is just the only strategies that we have in our hands to improve the follicle recruitment. Flexible antagonist protocol, trigger with agonist. In this case, we use the agonist trigger not to avoid the OHSS, but to reduce the time of the corpora luteal and to avoid the compromisation of the second follicular waves. Because the ACG trigger, this is our experience, this is the experience that we have coming from different duo-stim protocol. When you use the agonist trigger in back-to-back stimulation, you can compromise the follicle response in the second follicular waves. Why? Because the half-life of the ACG will be higher, because the ACG shut down the small follicles under 10-11 millimeters. So in this kind of the protocol, we use two different, the same identical protocol in 2 different ways. After the first pickup, we do the ICSI, we go to blastocyst, we do the PGT, we do the biopsy, and we freeze the embryo, we freeze the biopsy. Then we wait a second pickup, and then we do the ICSI, we do the blastocyst, we go to blastocyst, we do the PGT, we do the biopsy, and then we analyze the PGT in only one run. This is cost effective for us because the patients will pay the PGTA just one time. So this is just some specific protocol in order to not to make a magic solution, but just in order to reduce the time and increase the total amount of the gonadotropin in a short time frame. I think the question when we manage poor prognosis patients is the eggs. We have to try a solution to increase the number of the eggs. In order to increase the cumulative LIBOR rate, we have to minimize the dropout rate, because in this patient's population, even if in a public setting, we have a very high dropout rate, is around 40%. And also we have to decrease the time, because the time, of course, will compromise the future chance. This is my data. In my setting, we use 34%, according with my patient's population, this kind of protocol. So in 34% of the cycle, we use back-to-back 2 stimulation, okay? And here you can see in 2015, it was only 5%. So now the patients come to us to try to make this protocol, because they realize that 1 embryo, 2 embryo is not enough to individualize a euploid embryo, and to try to collect also more embryo, because the patients come to us not only for 1 embryo, the patient come to us for a family planning. And so having a one and done approach, I think this can be another solution to tailor the treatment. And this is just in 10% of the cycle, we use 2 duo-stim. So we try to make 4 stimulation back-to-back, okay? And why? In order to reduce the time in treatment. So this is a new indicator, time in treatment. How much time I spent in order to complete all the IVF journey. Another option could be a fresh duo-stim, for example, starting luteal, trigger with agonist, and start in the follicular phase. Okay, this is not a common way to manage patients, but this is something that we can use in poor prognosis patients, so in patients with a low chance, with high dropout rate, and in patients in which the time represent an important parameters. And the last but not the least, this is just my result. So up to now, we performed 3,300 cycle. Look, the competence of the oocyte when we collect the oocyte from anovulatory waves is the same. And in the second stimulation, always we have 0.8 more oocyte, maybe for the biomechanical effect of the first stimulation that we did in the first stimulation, or because the high level of the estrogen can be a priming in order to better synchronize the court of the follicles. The fertility is a process, and this is what you have to explain to our patients. This is the reason why multiple attempts are needed before to have a pregnancy, even if in IVF. And so I think this is something that we have to explain to our patients, because if we shift our mind from cycle by cycle to multi-cycle approach, in this patient's population, in all patients' population, we can reach higher success rate. And also we can reach a relative high success rate in poor responder patients according with the Poseidon definition. And so if we analyze the success for one cycle or up to 6 cycles, I think is totally different. And again, this is something that we have to try to discuss with our patient, and we try to make some solution. So I don't have time. Just the last slides regarding the important to have under control all the step in IVF. This is the paper that we published with the Italian Fertility Society in order to individualize some key performance indicators in every IVF, in all IVF setting, in order to analyze the clinical management, in order to analyze the IVF lab, in order to analyze the efficacy of the treatment, in order to analyze the safety of the treatment. So I think having under control all single steps, starting from the workup through the ovarian stimulation until the embryo transfer, is something that we have to do in order to optimize the chance for our patients. So thank you very much, and sorry for if I spend more time. Thank you very much.
So Alberto, thank you very much for the very nice talk. I'm sure there are questions from the audience. Would anybody like to ask questions to our distinguished speaker?
Thank you for your nice presentation. I have a question regarding the difference of post-receptor signaling induced by LH versus HCG. You have mentioned that the post-receptor signaling is unexplained, and it differs in terms of apoptotic versus anti-apoptotic pathway induction. Would you mind giving us more detail about the studies showing the apoptotic effect of HCG, because this contrasts with what we have been doing in our laboratory on the granulosa cells. Would you mind giving more details about this fact?
Yes, thank you very much. Maybe I am not the right person. We worked with an important Italian group with Livio Casarini and Professoressa Simoni. So they did a lot of research regarding the different pathway when you use when you use the LH or when you use the ACG. What I want to, according with my knowledge, what we know, and this is the old study coming from Filicori, is that if you want to if you take in consideration the effect of the ACG has mimic the effect of the physiological role of the LH. Of course, in the nature, we don't have the ACG in the follicular phase. The question is that apparently, if you look in vitro models, this signaling seems to be in favor of the LH. I'm totally agree that we don't have data or strong data according with the study in vitro, because in vitro we don't see, I think, this effect because the measure of the end point is not the right end point that we have in the study. Because for me, the effect, the ACG, and this is what we see in our clinical practice when you use the ACG trigger and when we want to study the cohort of the follicular phases, the ACG shut down the small follicles. So the ACG reduce the follicle recruitment. The ACG has an effect in the small follicles. Of course, this is something that we have to investigate, but the question is that I'm a physician. When I have different drug, I want to try to select the best drug. I want to try to have a clear vision according with my endpoint. And my endpoint is to, I am totally sure, I have the data that I cannot modify the competence. And so if I use the ACG, if I use the HMG, or if I use the other type of the gonadotropin, I cannot modify the competence. And we published a propensity score matching the last year, in which we did a comparison in different drug, with the same identical population. And when you have the ovocyte in the lab, the potential of this ovocyte is something unrelated to the type of the gonadotropin. I think that according with the evidence, maybe something that we have to investigate, but theoretically, what I think is that when you use these two different molecules, we have two different effects, and we can see this effect. It's something that we have to investigate. You are totally right, because the data are not very clear in the clinical setting.
Any other questions?
Thank you very much for your insightful talk, Alberto. So I have another question. In patients who you do plan to do a GnRH agonist trigger, do you use an LH threshold in which you prefer not to use?
Yes, yes, of course. If I have a patient in front of me with a eating disorder, with irregular cycle, with low level of the LH, so I want to check the LH.
On the day of the trigger.
On the day of the trigger. On the day of the trigger.
What is the LH that you use?
Yes, the cutoff is 0.5. If I have 0.5 of LH, so maybe I want to add a small amount of the ACG. Or another option is that if you individualize the patients before to start with the stimulation, you can make a mock cycle, a mock trigger. In a previous cycle, you can, in day 8, for example, you do a bolus of the GnRH agonist in the evening, and then you check the LH in the morning. If the LH will be more than 30, maybe you can be comfortable to use the LH without check, you can use the agonist trigger without check the LH level. But if during the stimulation, I see the low level of the LH, in this case, I want to add a small amount of the ACG, a double trigger, for example, because according with the data, I can have a suboptimal response.
Do you routinely check LH activity 12 hours after the GnRH agonist, or you just
Not
check it in patients?
No. In some patients, in PCOS patients, for example, because in PCOS patients, I want to be sure that the agonist triggers works, because because in these patients we can have theoretically we have a high LH level, but we can have a deficiency in terms of production, in terms of action of the LH, no production. So in this case, I want to check the trigger. I want to make a mock trigger cycle. Is just to be sure to make to don't be in trouble after
the day of the egg collection.
Yes, the day of the egg collection.
Thank you.
I have a question. In one of your first slides, you showed us that you need about 4 eggs to get 1 euploid blastocyst in a patient less than 30 years of age.
Yes.
And in a patient population who is greater than 42 years of age, the number of eggs that you need to get 1 euploid blastocyst, you showed it was 24.
Yes.
4 versus 24. So it's unrealistic. Whatever you do in terms of ovarian stimulation, you are not going to be able to collect that many eggs from those patients. And those patients are our primary focus in terms of decreasing success rates of IVF. The older patient and the patient who has a low reserve. In my opinion, I can go as far as to say that let aside the competence of the oocyte, I don't think that we have any maneuver at hand that we can change the number of or the quantity of oocytes in these patients by modifying ovarian stimulation protocols. And this is what we see in real life. You showed another slide of your data that was unpublished, but I believe it was an ESHRE presentation. And you showed 964 patients over there who were stimulated. And you said that the mean age was 39.2 in those patients. However, when we looked at the mean AMH level, it was 2.2 nanograms. And those patients are actually very good prognosis older patients. So those patients, whatever you do, will give you a good result. But I don't believe adding LH, adding whatever, putting add-ons on top of the treatment is going to make any difference in the aged population, especially who have a poor ovarian response. And the data regarding addition of recombinant LH on top of FSH, it has not been shown to work, especially I don't think there are any randomized trials that showed it was good to add recombinant LH on top of FSH only in patients who are poor responders. And moreover, if you look at data coming from previous randomized studies where they compared recombinant FSH with HMG, the number of eggs obtained with recombinant FSH only was higher in patients with HMG. So I don't know what your comments would be.
I have many comments. Yes, thank you very much for your.
Sorry for the long question.
No. It was really good because I have the opportunity to clarify some issue. So first, I am totally agree with you. 20 oocyte is amazing number. Okay. The question is that this is just a theoretical number because usually we try to make this prediction according with the blastulation rate and according with the aneuploidy rate. That's it. But maybe in the future we will have some tools to integrate different variables, and maybe we can make a good prediction. Because when you have one egg, you cannot predict the potential of the eggs. Because in many cases you can have 2 eggs, 2 embryo. So this means that unfortunately up to now we don't know the prediction. This is just to discuss with the patients how is difficult to reach the goal in patients at 42. But you know very well, because you manage patients like me, how many patients at 42, they come to you to say, okay, I want to do something. And you say, madam, I'm sorry, but the realistic chance will be 10% maybe, 10%. So I'm totally agree, but this is just to realize that the number of the eggs is, of course, we cannot manage the quality, but we can manage the quantitative. I totally agree with you that with the LH or with the HMG or whatever you want, we cannot increase the number of the follicles. But my goal is to improve the ovarian sensitivity. And we know that many cases we start with a 500 follicle count, but you can collect 2 eggs. And the question is that what can we do? Why I was not able to improve the follicle recruitment. And so the goal of the gonadotropin is not to increase the quality, is to increase the follicle recruitment. And the follicle recruitment is something that we have to optimize. Regarding the MAH, this is a very big point, because in our clinical setting, we don't trust in the MAH, or of course we prescribe the MAH, we look the MAH, but in many cases we have a very huge variability of the MAH. This data was a little bit older. It was an oral presentation in 2020. So the level of the variability of the MAH in my country across different labs was amazing, amazing. And so what I want to see is to look the ovary. I don't care about the level of the MHA. I cannot make my prediction in terms of success rate looking at the MH. The question regarding the study is always the same things. So if we wait the randomized control trial, maybe we can wait and we will not have the possibility to see nothing, because today making a randomized control trial is very difficult for many reasons. If you look the real world data, maybe the real world data can be something. Of course, so we can have inside a lot of variability, but of course we can extrapolate some concept. For me, we don't have data to assess the cumulative labor rate, because when you look all the randomized control trial in terms to make a comparison FSH plus MG, in all study the end point was the fresh embryo transfer, was not the cumulative. The only data that I presented coming from France was a real world data analysis in poor responder patients, and in severe moderate poor responders LH can be a different. So we know the story, we know very well the story. The point is that I need some indicators to assess the quality of my stimulation. The quality of my stimulation is to improve the follicle recruitment. All the time we discuss about which is the best approach, but I think we have to be further. The possibility to manage patients in different way, to start, for example, in luteal phase, to see the ovary, and because sometimes after the ovulation, we can see more follicles compared to the antral follicle count during the menstrual cycle. It's something that can we try to our patients. Of course, we have to explain to our patients the pro and cons. But really, every day I see patients, I see the 50% candidate for the egg donation. So in these patients, we have the egg donation, but also we have to try to make some specific strategies, because many patients, they don't want to do the egg donation. And so we have to be honest regarding the real chance. Of course, for example, the duostim is not a magic strategy, but it's something that can improve for me the cumulative chance, reduce the dropout, reduce the time. Because many patients jump from my centers to other centers to try to make something different. That is not true.
Yeah.
Thank you very much for your question, because maybe we can organize another meeting.
Yeah, I completely agree with you regarding the difficulty in addressing these patients. But still, I mean, of all the outcome metrics that you have just mentioned regarding patient cumulative live birth rate or whatever, I think the only metric that these are going to change is to keep the patient within the same unit. So keeping the patient and not letting the patient to go search for other treatments. I think that's the most that it will do. And yeah, these are extremely difficult patients. And the other thing is, like most of the studies looking at, I do agree that the stimulation should start at a time when you can observe recruitable follicles. I mean, if you don't see the follicles, the recruited follicles, the preantral follicles, there is no point in stimulating that patient. And sometimes that is also done. So maybe deferring by one cycle, asking the patient to come in the luteal phase to check after ovulation. So all of these are strategies that can be used. And in most of the patients, like in Poseidon group 1 patients who are hyporesponders despite having more follicles. And the studies that have been done on those patients are mostly before and after studies. So the study, the first stimulation cycle was done with FSH. And when the patient did not yield enough oocytes despite having a normal number of follicles, then LH was added in the next cycle. So it was a before and after comparison. And we all know that biology works in a way that there is always regression to the mean. So if you hadn't changed the protocol, maybe you would have obtained a different result anyway.
Very nice point, because but this is thanks, I think, we know all this knowledge because today we have to be flexible. I'm totally agree with you. So today what we do in our setting is that when the patients come to you the second day, if we see 2 follicles or if we don't see follicles, we wait. And we know very well the intercycle variability, because one cycle, one stimulation, different cycle, different response. But also thanks to this approach, we know the intercycle variability. And so I am totally agree with you. What I'm trying to say is that in this kind of the patients, to be flexible is crucial. This is the only way just to manage the patients. The point regarding the dropout, I think this is not an economic strategies. Because if you look in France, they have a full coverage reimburse of the IVF treatment up to 6 cycles. And they have 40% of the dropout rate in this patient's population. And so how can you explain why we have a huge dropout rate? Because we are not clear, because maybe we have to try to improve our counseling, have to try to explain to our patients that we have to shift our mind from cycle by cycle to multiple cycle approach. Of course, at 43, we cannot do nothing. At 43, the success rate is very low. But I think from my sides, the variability that we have, same stimulation, different ovarian response in different cycle, and also within intracycle variability, I think this is, very interesting. And so we have to try to improve our knowledge to try to promote the follicle growth or to try to promote the follicle recruitment, maybe in the previous cycle before to start with the stimulation. But this is thank you for your comment. Thank you very much.
Thank you very much, Alberto. And I think we have one last question, maybe, huh?
Okay.
Yeah, go ahead.
Alberto, thank you for your presentation. I want to ask if you're always using LH in dual-stim protocol, in your dual-stim protocol, and what's the ratio now?
Okay, thanks for this comment again, because so when we defined the dual-stim was a simple protocol. Our goal was to compare one protocol in 2 different follicular waves. We use priming, we use LH, because in this patient is the only option that I cannot increase more than 300 units, and this is what we know. But still, there are some units that they use more than 300, but there is no any sense. There is no any sense to increase more, and so we use recombinant, and the combination is FSH-LH. But of course, if you look at the literatures, you can use whatever you want. What you believe is true is correct in your patients. My recommendation is that don't use the ACG. Because if you use the ACG, you totally compromise the second follicular waves. And so the agonist trigger is crucial, because otherwise you can compromise the possibility to recruit new follicles in the second part of the menstrual of the cycle. But this is the protocol. So today we have the possibility to see the different protocol, the B-stim, the duo peak. So in every single protocol, you can see they use different drugs, different trigger, different LH suppression. So our protocol is very simple, as I showed before, but you can use whatever you want.
Okay. Thank you very much. I don't think there are any more questions. So we would like to thank you very much again for being with us, despite the broken leg. And I would also like to thank Merck for giving us the opportunity to be here and listening to your excellent lecture, and hope to be together again in the future.
Yes, thank you very much.
Thank you very much
for the question. Thank you very much. Bye-bye. Have a nice day.
Bye-bye.
Bye.